So this is our ECG webinar. We're actually going to be broadcasting here. If you're on our GoToWebinar, that's great. If you are on our stuff for YouTube, we're actually streaming this live on YouTube. So everybody always asks about their comments, and I can't see the comments. I can't see what's coming in. If you're on the GoToWebinar side, keep in mind, so we have this streaming in a couple of different places, so sometimes it is a little bit harder to kind of tell where things are coming in or where it's going. So I apologize, but not everybody can see everything where everyone else is. If it's something, I'll mention it. So you're free to ask questions and type them in the little question box there if you want, and I encourage it. If it's relevant to what we're talking about this at the time, I will mention it and we will go over it. And we'll go from there. I'm just moving around a couple of windows here. I have like 3 monitors and it's kind of a technological nightmare. And you would think as a tech company we would be able to do this very well. But even after doing this well over 100 times, it still takes just a minute to get everything, to make sure it's working, because the worst thing is to get started and then figure out that something's not working correct. So we've got lots of people joining in. We're so great to have you today. This is our ECG webinar. We're going to go over a lot of the basics and a lot of different things. So, oops, what did I do? Oh, I must have messed up my slides here. Oh, I'm on the wrong slide. Oh, look at that. So there we go. So my name is Dr. Kendall Wyatt. I'm the Academic Content Director at Picmonic. Now, I'm the Academic Content Director today, but this is my last live webinar that I'm going to be doing with Picmonic as far as scheduled. Maybe in the future, who knows, but I'm going off to residency myself. I'm going back to where I'm from in West Virginia and be doing webinars and other things there. So if you're looking for me, you can always find me on my personal YouTube. As always, I'll probably be I might be jumping in the future on some Picmonic stuff, but we'll be working on lots of other things. So I started out as a paramedic and then went to nursing school, then went to med school. And I love ACLS. I think ACLS is something that's really like a huge, scary thing for so many people, and it shouldn't be scary. And that's really the point, is, ACLS shouldn't be something that's scary. When you take your first ACLS class, it's 16 hours. That's a lot of stuff. So we're going to focus on a lot of the basics to make you good at interpreting ECGs and good at, of all the basic things. And we're going to go over a lot of rhythms, and then you're just going to need to practice. Now, if you've not heard of Picmonic before, what we do at Picmonic is we take all the things you need to know, and we take all of the things in medicine, and we turn facts into characters. Wow, my voice cracked. I must be going through puberty again. Even though the last time was late, I guess the second time past 30, it should happen. Something like bipolar should be, will turn into a bipolar bear. And if you need to learn about maybe warfarin, the drug, you're going to be able to learn about a warfairy inside of Picmonic. You can try it out for free. Lots of you guys are already subscribers. We appreciate that. You can check it out. There's tons of different topics. There's well over 900 topics for nursing, covering everything you need to know. Pharmacology, diseases, disorders, and all the crazy stuff that you just have so much trouble memorizing when you're in nursing school. And of course, every other type of medical degree. I understand. Now, what we're going to go over today, we're going to go over just a really quick hit on some basic anatomy, some high yield points on the anatomy side, but we're also, most importantly, is understanding the blood flow. I really think so many people fail at cardiology because they just don't really understand the blood flow and how to make sure that you memorize that first. It's super important. And understand the concept of it. And I know all the instructors out there, they say concept, concept, concept. But in reality, that's really difficult to kind of grasp. Well, what is the concept? Well, we're going to go over concepts of this stuff today. We're going to go over how to calculate the rate in a very crude, rudimentary form, and then we're going to jump into some rhythms. Now, after that, we'll do some review and Q&A if you have any particular questions. You can check out this recorded version. Will be on Picmonic's YouTube. It's live on there right now. You can check that out on YouTube at Picmonic Video. Just type in Picmonic Video or search Picmonic in YouTube. It's going to pop up. Look at our channel. It'll be the newest one. So let's go and get started. This webinar usually runs about an hour. It usually takes me a solid hour to go through this. If you're not planning to hang around for an hour, you can catch up and follow up later. But we do hit literally every high yield point that you need to know, all of the basics. So really, you need to know everything in this one. There's not really much that I say in this webinar that's like, yeah, you can kind of just brush over that. It's not really much here because we've already stripped all that out. Because we've taken really about 12 hours of what you would learn in ACLS and condensed it all down to an hour in a really rapid fire form. So maybe you need to watch it a couple times, maybe you need to slow it down, and I understand that and I get that, especially if this is your first time doing ECGs. Now, one of the things that's important to understand, and this is just one of our Picmonic images, throughout the entire webinar today, we've got lots of Picmonic images from our system, and it's not just a bunch of random images. You can go learn them all in there and check it out, but this is the coronary arteries. Now, one thing that's really important as you're learning coronary arteries is really knowing that there's the left coronary artery and the right coronary artery, and they really branch off the main two, the main bifurcation. Now, a bifurcation is where something splits, so it's bifurcate, bi means two, so it splits and it bifurcates, it creates into two. So you have the left and right coronary arteries. Now, one thing that's really important to know is that for the understanding that basic concept is important, because when you go and need to learn 12 lead EKGs, when you go into actually, if you're working, you need to do some ACLS and advanced things, you can really go in and learn and understand a lot of those basics of where the pathology is happening in the heart. And that's about all I'm going to go over with that right now. Now, one thing that is so important, and I just see so many people just brush over this, they learned it in anatomy class, and then they just kind of forgot it, or they don't have it at the tip of their tongue, is learning the blood flow through the heart. It's so important. Now, I'm not going to go through and drill basic rote memory tactics into getting you to memorize it, but what you just have to understand that we go from capillaries into venules and veins, then into those vena cava, into the right atrium. Now, the right atrium and the right side of the heart's all deoxygenated blood through that tricuspid valve, or into the right ventricle, and then, of course, into the pulmonary artery and the lungs. Somebody wrote in real quick and said they're having trouble just seeing intro screen. I think what you need to do, Anne, is you may have to, I can just reshare them here because it's streaming on our YouTube. So maybe let me just pause this and then start it over for you so that you can see. I'm surprised somebody didn't say something ahead of time. There you go. Hopefully, there you go. Sometimes the GoToWebinar system freezes on us, so you can always just write in there and let us know. So here, you should be seeing our blood flow slide now if you're on the on the webinar side. Now, one thing that's super important is, like I said, knowing that blood flow. Now, yes, you really do need to understand all of the blood flow, because then you can see the actual flow through the heart and understanding what's going on. Oh, it's still not coming in through. Oh, that's weird. Hold on one sec. Let me try something else here. Wow, there's a lot of people on here. Okay, so it's going to go away for a second, so don't freak out. Waiting and waiting and waiting. It's just trying to get some technical fun things going on here. It's oh boy, I got the spinny wheel of death. It's definitely not my computer. It's just usually software craziness. We're going to get it set up just in a second. Sorry for the people who are on YouTube. That's just annoying. Sorry. Just trying to make sure we've got several hundred people on our webinar panel, and I'm trying to make sure that that is working. Yeah, let's see. Let me see if I can get that fixed. Sorry for the delay. Marley's on our backup there for answering people on our YouTube channel. Just we are, if you're just joining in on the YouTube, it's we're just trying to fix a little problem with our GoToWebinar side. We always broadcast live kind of two places, and sometimes that doesn't always work the best for understanding, just because the GoToWebinar side sometimes will fail. It's not the best software, which is why we've been kind of going away from it. Not a big fan. But we do use, we do often do webinars from, oh, there we go. It looks like we're getting logged in. Oh, look, magic. Okay, let's see what we're looking at now. Okay. One sec. Okay, there we go. Now we should be seeing more. There we go. Okay, hopefully we should be seeing that on that GoToWebinar side. Let me just fix a couple other things. Sorry about the craziness. It just seems like no matter how many no matter how many of these webinars we do and how many technological times we do this, there are always something crazy that happens. It just seems like it always just kind of, maybe we're just trying to do too many things at once. Maybe that's just the problem. Who knows? Hopefully on the webinar side, you're able to see the slides now. You should be able to see the our wonderful blood flow, and feel free to just usually the little comment things goes, it just kind of really just fills up when something goes crazy. So you should be able to see the blood flow through the heart now. And to you guys on YouTube, sorry about that delay. So one of the things as we're going through and talking about this is, like I said, you do have to know this. You need to know it. I'm not going to harp on staying on it. But what is important is making sure that you know that the right atrium deoxygenated, right atrium, then to the right ventricle, then to the lungs. So then the lungs, then gets oxygenated, goes back out to the left atrium and the left ventricle, and then out. The point of that is the left ventricle is the largest. It's the largest of the heart. It's got to pump out to the entire daggone body, right? And it's huge. So it's huge, and it really has to pump a lot. So it's going to be a lot bigger. So then if we have that left coronary artery that essentially needs to, that if that artery gets blocked, then that's the left coronary artery, then we know that that's a big problem, because we're essentially cutting off all of the blood supply to the biggest part of the heart that's pumping. And that's what's really becomes a problem. Now, when you think about this is great when you go and you think about heart failure, which we've got videos on all that stuff. And all the other things, heart failure, and all of the other diseases as well. You can think about how something as simple as a myocardial infarction can essentially cause a lot of problems. It can cause, and you can think about the pathology that goes along with it. So I like to think about this with my wonderful fish tank method. Whoops, before we jump into this. So I just think of the body as a fish tank. These all go together. The pipes are the veins and arteries. The pump itself, the heart, which is what we're talking about for electrical rhythms. The aerator, in every great fish tank, you need something to pump oxygen in there. So we've got our lungs. And then the tank and the fluid is just like the fish tank itself with water, which of course is the actual body keeping everything together in the blood. And then everything needs a great filter like the kidneys. And we've got these little filter kidneys here. I got my orange cup here today with me. So my mouth gets dry, so I always have to take a little drink. Now let's jump into EKG stuff. Now that we're finally going, wow, it's just that's painful. So one of the things I want to talk about are the electrical physiology of the heart. Now, when we talk about the electrical physiology, we know that we have to talk about the sinoatrial node. And we've got this sinoatrial node here. We've got our little spark plug. And that's what's really important to know, that it's at the top of the heart. So electrical activity comes from up here, and it comes down from the right side there all the way down to the left ventricle. It comes from the sinoatrial node to the AV node. We've got our little aviator wearing heart. And then, of course, it goes to the bundle of His, and we've got our hissing snakes, and then down to the Purkinje fibers and out to the rest of the heart. Now, when you think about this conduction system, what you really need to know is that each one does different speeds. And this is an important concept, again, to think about. Because what happens is it's really like a backup system. It's like having a buddy system, and if one fails, then the other one's going to step in and help out. So what happens is the sinoatrial node, they all have different rates which they kind of kick in at. And that's really the concept to think about. So when you think about somebody who then has a heart block, which we're not going to go into the ECG of heart blocks, but they have a heart block, so they have blocked the electrical system, that person is not going to have a fast rate, right? They're going to have a very slow rate. So let's talk through that. So if you talk about the SA node, the sinoatrial node, it has a regular beat, an intrinsic rate of 60 to 100 beats a minute. That's essentially a sinus rhythm, right? Sinus rhythm is intended, it matches a sinoatrial node firing from the sinoatrial node because it's essentially firing from the normal place and firing correctly. And that's really what you can think about. So if it fires from that right atrium, the SA node, comes down through the right atrium, down into the AV junction, the AV node, it's often called, or the atrioventricular junction. Now, the AV node is the second spot that it gets electricity. So it comes from the SA node to the AV node, then it comes all the way down and then essentially fires throughout the rest of the heart. Well, if the SA node fails, if something happens and you have a heart block, a blocked conduction pathway, essentially what happens is the AV node can take over. It can work all by itself because that's one of the great properties, but sometimes albeit bad properties of the heart is that they're automatic. They can conduct themselves, and if I'm energized and I'm in a cardiac cell, my buddy over here who's a cardiac cell, if I'm electrified and I go bzz and I shock him, he's going to fire right beside me. So it conducts all the way throughout the heart tissue as well. And that's one of the great things, so that the AV node can essentially fire in the middle of the heart, and that's where you see all those weird problems where you see inversions of like the QRS complex, because it looks weird, but that's because of a probable problem. And there's very identifiable patterns that we see on the ECG that we're able to keep track of. The last part are the Purkinje fibers. So down from the AV node here, out down, then we have these Purkinje fibers, and they go out through the ventricles. The Purkinje fibers are the backup. They come in at 20 to 40 intrinsic rate. And then they're really just kind of the true backup system. Sorry, I can't pronounce your name. Stenitis says that they heard Stitch, and that's right. So since usually I put Stitch in another room and kind of hide him off to the side, but he's here with me today. So if he does bark, I'm sorry, but he kind of has dependency issues. So as I talked about, the cardiac cells themselves, they're automatic and they conduct themselves. They excite themselves as well as they are contractile. Now that's a bunch of basic stuff. Let's talk about ECGs themselves. When we talk about the ECG, you got to know the parts. I mean, if you don't know, it's like reading the user manual. You have to know the basics before you can really just dive in. Otherwise, you're destined to fail. So let's talk about this. So we have the P wave. Now, one of the things I talk about are the PQRST, and when I hear people talk about it, like, oh, I can't remember that. If you can remember the alphabet, you can remember the PQRST. So just remember that the P starts first. Now, I know usually Ping is last, but in this case, we're going to think about the P first. So when we talk about the P wave, what happens, the P wave is the first deflection above this isometric line. The isometric line is essentially this imaginary line of wherever the ECG kind of resonates to a base. So we have this, so this would be on the isometric line before the P wave. So that first deflection above the isometric line is the P wave. And then we've got the Q, which is usually the QRS complex, which we're going to talk about again in a sec. And then the last is the T wave, or the T, and that's the deflection after the QRS complex. And you need to know what each of them do. Oh my goodness. Poor GoToWebinar just is a complete fail today. That's not cool. I am actually going to change over something here. You should be seeing the EKGs. Do you see ECG pieces, guys? Maybe on the webinar side? Nope. Oh, okay. Ah, wow. Okay, so I'm going to just change some stuff here. Sorry about that. Okay, let's see. Maybe we can. Yeah, so somebody did write in, maybe we could just watch on YouTube. Yeah, you could do that. You can also kind of pause and replay on YouTube. That's one option, but there's so many people in here, I'm not going to make all of you do that. Let's see here. Turn this off. So many. Oh boy. Sorry about the delay for the lots of people watching on YouTube. Again, just a little loving technical problems. Oh, actually there's several of you guys on the on YouTube. We appreciate it. Sorry for the delay, but we are going to be. I'm just trying to fix something here on the GoToWebinar software. You know, the YouTube software never messes up unless I push the wrong button. I'm just saying that. Let's see. Fix this. Just gonna have to. Just annoying. Okay. One sec here. So many people in here too. That's just crazy. Okay, so we should be working maybe now, I hope, and you're more than welcome to jump over to YouTube because it doesn't mess up over there. So let me just, Marley, if you actually paste the link in to GoToWebinar and you click send to all, that way everyone can see it. So you can jump in over there if it messes up again because I'm not going to fix it again. I don't know why. I don't know why it's breaking. It's out of my control. It's not something I can control, unfortunately. So sorry about that. I am sorry, actually, because it annoys me and it just adds an extra 5 minutes of boring audio. Nobody likes that. Nobody likes to watch me. And it's like super hot in my house today, so. Anyway, so as we're talking about the ECG pieces, like I said, PQRST, you've got to know all the pieces. Now we've got a wonderful Picmonic to help you with this. You can go check it out. We've got our little queen and then our little R rocket, our little S for shooting down, and then of course our T trophy to help you remember PQRST as well as learning. Now, one of the things you've really got to know is you just got to understand what's going on with each of the pieces of the ECG. So the P wave essentially is atrial depolarization. Well, what does that mean? Well, that means the atria are depolarizing, right? Well, that means they are discharging, and essentially that's the electrical contraction, the electrical activity that's causing contraction, depolarization. And of course, it creates a little indentation. And then the QRS complex itself, so from the start where the Q deviates down to the isometric line all the way to where the S returns to the isometric line, the QRS complex is ventricular depolarization. So that's where the ventricles depolarize. The electrical activity fires and the ventricles depolarize, which essentially should equal contraction. Now, what's interesting about ECGs is that just because there's electrical activity, that does not necessarily mean that the actual muscle is doing that. An ECG is only measuring the electrical activity. So of course we have something called pulseless electrical activity, right, where it looks like there's a heart rhythm, but there's actually no heartbeat, there's no pulse. And that's really important because it's just sporadic electrical activity that happens that's measured on an ECG, because that's exactly what an ECG does. So you can go in and, again, check out those different pieces. Here's just an example of the Picmonic, how we talk about atrial depolarization, ventricular depolarization, and then repolarization of the ventricles. Now here's where you really just need to make sure that you understand this concept. The ECG paper itself is super important to know how it works. You've got to really understand, to be able to calculate the heart rate, it's actually really simple. So many people get caught up on math with this, and they just get so confused and they're just, I'm not sure what to do, or I can't really get it. All you have to do is essentially, then you have to look at the little tiny boxes, and this is a great example here. But what the point is each box breaks into smaller boxes until you've got to the tiniest little box. I think I've got this on the next slide. Yep, I did. So on the tiniest little box, right here, we got the tiniest little box. You need to remember that one, and that's it. You need to remember 0.04 seconds. That's what you've got to memorize. If you memorize that, you can build off of that to all of the times and how the ECG measures. Because when you have the printout of ECG paper, you may have green paper or blue paper, or maybe you have, I don't know, rainbow paper. Good for you. I'd like to see some. But the point is, it's usually, it all looks the same. It's all the same grid. And inside of here, from left to right, it measures time in seconds. And then measuring the height is essentially measuring, we could say maybe the intensity as a generalized term. Yes, I know that's not, if you're super nerdy, that's not entirely correct. But that's enough of a concept to understand what's going on. So 0.04 seconds. So what happens is, yeah, the green paper for sure. So what happens is the 0.04, the tiniest little boxes, everything goes in multiples of 5 here. So you got to remember the multiples of 5. So if you remember that 5 of the smallest boxes in here going across right here, as they're evidenced right here, that equals 0.2 seconds, 0.2 seconds. So 0.04 times 5 is 0.2 seconds. So it's 1/5 of a second. That's correct. So then, of course, if I have 5 of these sets of the tiniest 5 small boxes, then that equals 1 second in duration across. So that's essentially 25 of the smallest boxes of 0.04 seconds. And when I say that out loud and everybody hears it for the first time, they think, wow, that's confusing. And I know it sounds like a lot of numbers thrown at once, but it's essentially 0.04 seconds at the smallest one. Now, whoever thought of this, man, they're super smart people, because what happens is we need to know what's so important that we need to know about what is so important about this 0.2 seconds. What's so important about that one? Why is that such an important number? Why is it such an important number? Well, that's right. The 0.2 seconds is where we measure heart blocks. We're measuring that period of time, and that measures heart blocks, and that's exactly right. So with that, moving on there, the biggest thing you've got to do next is be able to calculate the heart rate essentially. Now, I like to use just a simple example, and yes, I am simplifying this. No, it's not going to work 100% of the time, but it's going to get you so close that you can always get close enough with your answer. Now, when you look at a 6-second strip, how do we know it's a 6-second strip? Well, what's really great is, see how this is 1 second right here? What's the minimum amount of time we need to have to interpret a proper EKG? 6 seconds, right? So what's really cute is that inside of these, at the bottom of every paper, there are lines. There are lines that jettison down from the bottom, and they're usually little black lines. Now, there's variations in this, yes, but the point is that these variations in these little lines are usually at 3-second intervals. So they're usually 3-second intervals, and then they jump over. So there's 3, and then that's 3 seconds, and then that's 3 seconds. So if I count 1, 2, 3 lines, or in between 2 and skip over 1 line, that's a distance of 6 seconds. Now, what you don't want to do is waste your time and try to count all the tiny little boxes inside here. Well, how can you do that? Well, see these bolded lines? All of the ECG paper is bolded inside of here. So it's bolded inside of here, and it's bolded, and then it counts across over the lines. So that's 5. That breaks it up into 5. And then there's an even bolder, darker line for another multiple of 5. And that's absolutely correct. So you can just go from here and then go over to the other multiple of 5. So that's just where it works. But what we need to get is a 6-second strip. So if you know your ECG, you know the basics, P, Q, R, S, T, then we can identify here, look at these long lines. So there's a long line, here's a long line, and here's a long line. So that's 1, and then there's 2, so that's 3 seconds in between there, and then there's 3 seconds in between here. This particular paper actually counts every 1 second for us with a tiny little line. But just remember the longest signs, the longest line. So that's 3 seconds, and this is 3 seconds. So we've got a 6-second strip. Well, how do we get a heart rate speed? Literally super simple. All you have to do is identify the QRS complexes and count those, multiply it by 10. That's it. So let's look at this. So here we've got a P, a QRS, and a T. A P, QRST, PQRST, PQRST, and PQRST. So here's 1, there's 2, there's 3, there's 4, and there's 5. So there are 5 QRS complexes in this 6-second strip. So all I have to do is take the 5 QRS complexes. How do I then know the heart rate? I multiply that by 10, and that means I've got a heart rate of about 50 here on this example. Now I say about because I can also, there's another way I can measure the heart rate. Lots of you guys have jumped over to the YouTube, and yes, YouTube is delayed. It's delayed a little bit, so if you just haven't caught up, that's good. So you didn't miss anything. So I did put a delay on YouTube the way we stream it, just for technology's sake. There's no rule against it, but it's just I don't know. Seems like fun. So if I look at this 6-second strip, so there I've got 1, 2, 3, 4, 5. So I've got about a heart rate of 50 because I multiply that by 10, and that's absolutely correct. So I can multiply that by 5, and that's going to give me a heart rate of about 50. So now what if I need an exact heart rate? Well, here's where the question comes in. Almost all of the time, unless you're literally taking an ECG class at this particular time and you're getting lots of ECGs and getting just literally drilled on them, the quick method always works. It's going to get you close enough. Almost always you're going to get answers that are going to be far away. You're going to see an answer that's 40, 50, and you're going to see an answer that's 70, see an answer that's 30, and see an answer that's 26. So it's very close. Which one's the closest is most likely to be your answer. But if you need an exact answer, what you can do is count the number of boxes or the amount of time between the R to R interval. So here's a PQ, so PQR. This is an R wave. So I can count the difference in time between the R's and see how much time that is total. I could count every little tiny box, or I could count the multiples of 5. So there's 3, so 8. So wait, 5, 10, 15, 20, 25, 30. So there's 33. I multiply 33 times 0.04, which is going to give me 1.32 seconds. And then I just take 60 and divide it by 1.32, and it's going to give me the exact heart rate of 45. All of the ECG monitors and all the heart monitors out there, what they do is they actually count from the R to R. They're able to identify where the R wave is, and they calculate the exact difference in real time of the R waves to give you an exact heart rate. Now, one of the things that, well, I'm not going to talk about that. So anyway, looks like a couple of people are having some interesting troubles there on the still on the GoToWebinar thing. I can't keep like freezing it. I don't know. I can't fix it, unfortunately. I don't know that it's anything maybe out of my control. But one thing is important. You can jump over to the YouTube, and then you just need the link, and you can see it there to get it. There was a new update to the software, so I don't know why it's definitely not working. But you don't need any kind of login or anything to view the live webinar. You just need the link. You just go to our page and click there. So it looks like most of the people have jumped over to there as well. So the link is there. You should be able to see it. Marley can jump on and give you the link, and Marley will help you out. One of the next things is let's try an example of our heart rate speed here. So here's our 6-second ECG. What's the heart rate? What's the heart rate here? What do you think the heart rate is? Well, what do you got to do? Well, what you have to do is you have to count those. I mean, you could count the distance between the R to R, but that takes too long. We need to be fast. I mean, you only get 1 minute and 20 seconds on these questions when you're taking your boards, right? So, I mean, what do you need to do? Well, you need to count how many QRS complexes there are. 1, 2, 3, 4, 5, 6, 7, 8. There's about 8. So this heart rate is about 80. And almost all the time, literally almost every single time, you're going to be able to know exactly what's here, and then you're going to be able to see if that's a slow rate or a fast rate. We're going to talk about that. So I'm not going to go into too much into the intervals themselves, just because I'm running behind. I don't know if it's because I'm talking so much or because the GoToWebinar mess-ups distracting me, but we talked about the P wave itself. There's something called the PR interval. And we know the PR interval needs to be less than 0.2 seconds. Now, what does that match to again? Remember those 5 tiny blocks, the 5 block of 5, that's 0.2 seconds, so that's 5 blocks. And what happens is that's a delay in conduction speed from the atria going down to the ventricles. From the SA node to the AV node, it's a delay. And when it delays, it's delayed because it's blocked. Oh my God, somebody was so smart who thought of this stuff, right? Because it just makes sense. So if this is delayed, that's called a heart block. And there are lots of different types of heart blocks, but essentially the number one sign of a heart rate is heart block, is a delayed PR interval, which means it's greater than 0.2 seconds. Now we've got our QRS complex, which needs to be less than 0.12 seconds or 0.1, but I like to use 0.2 just because it's so, it's 3 boxes again. And again, if you can see more than 3 boxes in there, that means it's delayed and it's going slow. That means the depolarization process is going slow throughout the ventricles. That happens often because of conduction problems and other injuries and myocardial infarctions and whatnot. We've got the QT interval. The QT interval is from the Q to the T, so it's essentially the distance from the time that the heart depolarizes to the time the heart repolarizes, or the ventricles, I mean. Why is that so important? Well, when we think about that, what happens is we can have something called R on T phenomenon. And what happens is R on T, well, the R is on the T, and the heart is trying to depolarize and repolarize at exactly the right time. And it's because that time gets stretched out, and then it causes this abnormality, and that's where we get sudden death. That's why one of the reasons why we have these type of phenomenons are one of the reasons why we have defibrillators in every single school and every single thing now because of this abnormality. And then of course it needs to be shocked, and the heart goes back into rhythm. That's just, and then of course there are lots of drugs out there that cause QT prolongation that you need to know about. The ST segment is the most common thing. Of course, that's from the QRS to where the T begins to deflect above the isometric line, the ST segment. And of course that particular segment is where you can measure basically cardiac injury, essentially. That's where we see that cardiac injury, ischemia, or death. Now, there's a couple of other important ones, and you really got to know these. I've just got the most important ones here. I talked about that prolonged QT already, but what about a U wave? Where do we see a U wave? I didn't even mention the letter U yet. It's like I'm, oh goodness, what is that guy? He's like, let's talk about the letter U. What's the U? Well, the U wave is PQRST and then U. Essentially, it's another wave out here after the T wave. It's another one. There's another little wave. It's not another P wave, and I don't want you to concern it for that because it's really difficult to be able to identify a U wave. Most commonly, you're going to be told about a U wave, and then you need to know that it involves potassium. And exactly in the opposite, this tall peaked, it involves a low potassium, so hypokalemia. And I just remember that a U wave is shaped like a U, so it's a decreasing potassium. Now, when we talk about the T wave, this tall peaked T wave, this one you're going to see very often as well. And here's a great example. So I got my P is right here, kind of hard to see, QRS. And I got this giant T wave. I mean, it almost looks like a QRS complex. It's bigger than, but it's after the QRS, and it's a giant T wave. It's a tall peaked T wave. Number one sign of hyperkalemia in the tall peaked T wave. And that's really important to make sure that you know. A tall peaked T wave. So just make sure that you know that stuff. Those are two ones that they're so commonly tested, but also if you have a patient who's just fidgeting, or twitching out of control and they're having problems and they're a renal patient, then you find out that, the tall peaked T wave, well, that's because, you're going to see that on the ECG and you're like, wow, that person may have hyperkalemia. Look how tall, look at that T wave. That's crazy. And of course, then you can treat that. But remember that potassium is very, 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 cardiac, it's very, it affects the cardiac system a lot. It affects the heart, and imbalances are, the heart's very sensitive to those imbalances. That's why we can see it on the ECG, and of course it causes arrhythmias very easy. So here's just our potassium Picmonic, so you can go check that out if you want. So I'm just going to kind of skip, I kind of already talked about each one of these, but I want to talk about the ST segment. So as we look at the ST segment, this segment right in here, this between the ST, we know that the ST segment essentially can be what? what is the ST segment? Well, the ST segment, if you're thinking about cardiac injury, yes, that's absolutely right. So you're thinking about cardiac injury, the answer is yes. It's not, it can be cardiac ischemia and then cardiac infarction. So ischemia just means oxygen starvation. So it just means that it's oxygen deprived. Whereas ischemia actually means cell death. So if we have cardiac ischemia, we may see a depressed ST segment. But if we have cardiac ischemia, a true infarction, that's where we see that ST segment elevation, and that's absolutely right. So that's where you'll see that, and that's just really important to make sure that you know those. Here's our little ST segment deviations. These are important to knowing in infarction. Here's some examples. So here we've got under the B here. Here we see this P, QRS, but the S doesn't ever go back to the isometric line. Well, that's because we got our S. The S is almost gone, but it's there. I mean, you got to understand it's going to be where it comes down and starts deviating back to the new isometric line, what it thinks is. And then we got coming over to the T and then back all the way down. Opposite of that, over here under our C example, we've got our P, QRS, and then it comes way down below the isometric line before coming back above to the T wave. So somebody asked about, will the T wave be obvious, Stephanie? And how big is the T wave going to be in hyperkalemia and the changes? It really just depends on the severity of the potassium imbalance. It could be huge. It could be like the example that you see there, but you're probably going to see other types of symptoms. It may not be obvious, but what it may not be is it may not be a beautiful rounded. It may look like a teepee. It may not be very big, but it looks like a teepee, and that's because it's literally rapidly depolarizing straight up and straight down. It may look very pointed, and that's why we call it tall and peaked T waves. And you can, there are algorithms being able to check the T wave to the QRS complex. That's the physiology stuff. I'm not going into that for what we're going to talk about now. Now, when we look at a myocardial infarction, the ST elevation that you see could be very different. And I don't want you to focus on trying to always identify ST elevation. I see so many people learning ECG in the beginning, and they're just so focused on trying to find ST elevation that they're not focused on making sure that they're just good at reading ECGs. So there's just some examples. So they can always look differently. Look how this one looks different from this one. This one looks different from this one. These are all ST segment elevation. So there's no P wave in any of these. That's on purpose. But QRST, QRST. Then we got a QRST. And then we got a QRST. So it's going to look different. And it's based on the evolution of the myocardial infarction itself. So all of that, lots of basics, lots of things to understand. I get it. If you don't understand all of the basic stuff, I recommend making sure you really know that. But number one, you've really got to know how you can calculate a good rate. That's what's super important. You got to be able to calculate a rate, and you got to be able to know how to get the rate correct and make sure that that is indeed working. And that's definitely one of the things that you just have to know. We're going to go through some rhythms. But first thing, when you learn anything, I think when you're learning any type of new skill, and I'm not somebody who usually harps on so many basic things, but you've got to learn a process. It's just like baking a cake, doing ECGs. It's like doing anything. You've got to follow a very certain pattern. Otherwise, you're guaranteed to make mistakes, because then you're going to just keep ending up with, what do I do now? This one looks weird. Ooh. That's not what you really, that's what's going to happen to you if you don't follow the pattern. And we got a pattern here for you. If you've learned ECGs in a little bit different order, that's probably okay. So you don't have to follow my order exactly, but it is a set order that it does equal success every single time. And then there's the weird crap at the end where there's a few anomalies that you just have to know. And we'll talk about some of those as we go through. So as we go through, this is what everything we're going to run through today. We're going to go through, if anything, making sure you're a master of the process, because that's what's going to make you be able to understand what's going on and just not make any of the, what I want to call basic mistakes, right? The things where you're like, oh my God, I can't believe I missed that. Because that's where so many people with ECGs, they miss those. They miss the basic stuff. And if you're saying it's not you're not that person, I'm telling you, I worked as a paramedic for a long time, and that's one of the big paramedic skills is doing ECGs. Oh, I was so bad. I didn't realize how bad I was until I relearned it and always follow the same process now. And I think that's really, use my learning example. Don't just don't do what I do. So we're going to talk about, first we're going to go through looking at the rate, and we're going to run through this, each one. We're going to look at the rate, and we're going to determine the rate. That's the most important thing, because then is the heart going too fast or is it going too slow? We're going to look at the rhythm of what's going on. We're going to see if it's doing the same thing, if it's regular, or if it's irregular. Then if it's irregular, we're going to break that down, and we're going to say, is it doing the same thing every time, or is it doing a bunch of weird crap? After that, we're going to look at the P waves, and we're going to say 3 questions. We're going to say, is there one before every single QRS? Are they upright? Are they consistent? Upright, rounded, and consistent. Then we're going to look at that PR interval, making sure that it's less than 0.2 seconds for what? Heart block, yes. And then we're going to look at the QRS complex itself. We're going to look at the QRS complex, and basically the last one is like, is it wide or is it short, right? Is it greater than 0? I like to say 3 boxes, just for simplicity's sake. And you see some variation in the text on 0.1 seconds. Woo! There's a little Freudian slip for you. And then 0.12 seconds. But you're going to see that, and then I always just in my mind think 3 boxes, because I know 3 tiny boxes are 0.04 seconds apiece, times 3, 0.12. Mainly because I'm a math nerd. Now we're going to look through this, and we're going to run through these examples, and we're actually going to run through this together. So if you didn't catch all this, don't freak out. I didn't intend to harp on this giant list, because we're literally going to run through this, every single one, and as we start with the basics, a basic regular rhythm, we're going to build each one, and we're going to go through it, and we're going to see how we're building through the process. Because if you can get the easy ones, then you can move to the harder ones, and the harder ones, and the harder ones. Yep, you'll get it. So let's talk about a sinus rhythm, okay? I'm not going to read all of this crap to you, because I think it's a waste of time. You can watch this later. You can scribble it down. I think I've got the DVR turned on YouTube, so you can actually pause it and stop me. And it's still going to be playing on YouTube, and you can stop me and make some notes, and then you can push play again. It's all there. I'm pretty sure I turned on the DVR thing. It's one of the great things I love on there. But what's really important is a sinus rhythm. Well, what does a sinus rhythm mean? Well, a sinus rhythm means it originated, hopefully, from the sinoatrial node and traveled down through the right path to the AV node and then out. Sinoatrial node. So that means it originated from the sinoatrial node, sinus rhythm. That's where that comes from. Sinus doesn't mean your nose sinus. It means normal, regular, expected, all those whatever synonyms. Now, when we look at this, here's the same pattern. You're going to notice this exact same thing: rate, rhythm, P waves, PR interval, QRS. It's going to look the same way on every single one of these we look at. You don't have to go into the details on each one. And when I talk about the leads and all this stuff, don't even worry about that stuff when you're starting out. I think you need to know lead placement, and that's a separate talk. I had to cut it out of this because it's just too much stuff. But one of the things, so you got the rate, rhythm, P waves, PR interval, QRS. In a sinus rhythm, let's look at the rate first. What is the rate? Let's say this is a 6-second rhythm. What's the rate here? Someone tell me the rate. So somebody count. I can't count today. I should make like a cheat sheet for myself. 1, 2, 3, 4, 5, 6, 7, 8. So it's about 8. Actually, this is the same rhythm I just showed you a minute ago. So that I just realized that. So the rate is about 80, right? Now, when I say the rate, when I talk about fast and slow, what's a normal heart rate? You got to know that one. 60 to 100 beats in an adult. 60 to 100. Is it faster than 100 or lower than 60? No, it's normal. That means it's a normal rate. Rate, regular. Now, rhythm. Now, here's where it gets a little tricky. Rhythm, you've got to be able to say, is this doing the same thing over and over and over and over and over and over and over? Yes or no? Now, how do we do that? Now, first time I'm going to explain it to you with the perfect one, and then when we get into the harder ones, we're going to have to do some finger motion. I like to use my thumb. So when we look at the rhythm, the way you tell if the rhythm is regular, what you actually have to do is you have to check you have to look at the R to R interval. So here's the R, there's an R, there's an R, there's an R, there's an R. You get the point, right? And then you have to say, are they regular? Now, I like to use the thumb method here. This is my beautiful thumb. I have the most beautiful thumbs that anybody has ever had in the world. These are the best thumbs, and I know thumbs, okay? So I like to just literally every time, whether it's on an ECG monitor, whether it's on anything, I literally just thumb it. And I take my thumb, and I literally just put my thumb right up there, and I angle it to where it's about right, and I just eyeball it, and I'm like, yep. It's almost the same distance all the way across. There's no wide variations. Thanks, Duckbutt3385. Great name, by the way. Thanks for the thumb compliment. For you guys on GoToWebinar, Duckbutt3385 just gave me a compliment about my thumb. So what you need to do is see if it's regular. Is it the same distance? What you're looking for is you want to see if one's scrunched together or one's farther apart. That would be maybe not irregular, and we're going to talk about that. But you don't just have to look at the R to R's. To truly say that it's regular, you have to look at the P to P's too. So you got to look at the P to P's. So you're going to be able to identify. So there's the P. So P, Q, R, S, T, right? So there's my P, and there's my other P, 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 P. And I'm doing this one slowly on purpose because you're going to have to be able to do this, and it gets harder. Of course it gets harder. That's the whole point. That's why this is a difficult subject. But what the important thing here is that you've got to be able to understand the basics. So this is the normal rhythm. I'm telling you it's normal. And when we look at harder ones, then you're going to have to be able to figure it out. Somebody asked, is there a handout? You can always check this out on YouTube. I do have a PDF of some sample rhythms for you to try, and I'll post it in the link of the video afterwards, or I'll send it out in the email. It's just a rough set of rhythms, and you can just try them on your own, and then it has the answers. But as far as a handout, you just kind of have to watch the YouTube. Getting back to our regular, look at our P. So I take my beautiful thumb again, the best thumb in the world. I mean, I know thumbs. There's no thumb better than this one. Magical thumbs. Then I take it and I put it down there, and I'm looking at the distance again. So I'm looking at the distance, and of course, when I look all the way across, they're very close. Now, when I say close, I mean if it's one box away, 2 boxes away, perfectly normal. We're not trying to micro scrutinize this. This is a rough thing, and it's it's supposed to be, because what is one thing that will create a variation in a heart rate in a normal, healthy individual? And you got to know about this for real life. On the test, they're not going to give it to you. But actually, I think I have a slide on this, so maybe I shouldn't talk about it. But one of the things that changes your heart rate is breathing. If I take a big, deep breath, what happens if I hold that big, deep breath in, or I took a big, deep breath? I've increased the pressure in my heart, or in my intrathoracic cavity. I've caused increased pressure. My heart then can't fill as easily, so my heart rate needs to speed up a little bit. And that's called a sinus arrhythmia. It's a little beat that's just going to be a little bit off place. That's perfectly normal. If you're seeing it slowly speed up, just a little bit over a couple of beats, perfectly normal. I think I have an example here to look at it. Now, looking at the rest of it, is super easy. For this, I look at the P waves and I say, are they upright, normal? Is there one before every single QRS? Yes, 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 yes. Yes, there is. Then I look at the PR interval all the way across. Beautiful. I mean, there's no way I've got 5 boxes in between there. Not a chance. Then I look at the QRS. There's not a chance, literally, just even glancing at it. Is there more than 3 boxes in between that QRS? Not a chance. I don't even need to look at all of them and tell you all the way across. Absolutely not. So when you kind of condition yourself, you quickly get the basics, and we're still basic stuff. Then when we start doing these faster, we're going to go faster and faster and faster and faster and faster, right? That's the idea. So let's look at this one. Tell me what the rate is. This is a 6-second strip. You have just a few seconds. What's the rate? The rate is about 50, right? The rate is approximately 50. Approximately. Now, 50, is that between 60 to 100? No. Is it fast or slow? It's slow. It's a slow rate. It's approximately 50. It's a bradycardic rhythm. Now, is the rhythm regular? Ooh, I could have a little bit bigger thumbs for this one. Look all the way, my R to R's, yes. I look at my P to P's. P to P to P, 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 all the way across. Beautiful. Very consistent. Is there one P wave? P, QRST, PQRST, 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 PQRST. Yes, beautiful. So if I look at that, then I look at this rhythm, when I look at the P wave, how do I know that this is a sinus rhythm? I forgot to mention this on the last one. I know that this is a sinus rhythm because there's a P wave there. It's there before every QRS. That means it's and it's positive. It's upright. And it's one before every QRS. That P wave right there, that little nugget, that P wave tells me that originated from the sinoatrial node, meaning it's a sinus bradycardia. So it's originating from the sinus, the sinoatrial node. There's one before every Q or S. That means it probably caused it, right? Yes. And that means then that that's a sinus bradycardia. So that means it originated from the sinoatrial node. Come here, Stitch. Sorry, my Stitcher's here is about to have a moment, I think. I don't want him to bark. So so that's how I know that that's a sinus bradycardia. So Jack, for you, just important to make sure you know, and maybe you're answering something because there is a little bit of a delay, but what's important to think about when you say bradycardia, make sure you're always saying sinus bradycardia. Because if it's not sinus bradycardia, then you know that it may be, that's where we get into something called junctional rhythms. Junctional because of the AV junction. That means it didn't originate from the SA node. If there's no P wave, that means it's junctional. That's just a side note. We'll talk about that here in a second. So let's look at this one. Someone tell me the rate. 13, right? 13, 130. The rate's about 130. Beautiful. Now let's look at the rhythm. You got to have really tiny thumbs for this one. And I don't have tiny thumbs. I have big, beautiful thumbs. But if you have tiny thumbs, wow, I couldn't imagine if you're on a mobile device and you're really trying to use your thumbs. But if you look there, it's regular. The R to R all the way across is beautiful. The P to P. Now I know it's hard to see those P waves, but they're there. Look, they're right there. P, P. And as the rhythms get faster, it's harder to see the P waves. Yes, it's absolutely right. It's like having a toddler. This Stitches. He's just like a toddler. So that's absolutely right, and it's regular. And the R to R, also regular. So R, all the way across. Now there's a P wave. Is there one before every QRS? Yes. Is it upright? Yes. That means this is a fast rate, right? Because 130 is above 100. That's right. We did math. And it means it's a tachycardic rhythm. So you say tachycardia first. Then when you look at, and you say regular, yes. Then we say P waves. There's one before every QRS. That means it's sinus tachycardia. So then we've added tachycardia. Now we say it's sinus tachycardia. And that's how we know exactly what it is. PR interval, of course, on a fast rate, it's really hard to see a true heart block. So we're going to look here. There's no way there's any of those are greater than 0.2 seconds. So from here to here, no. There's literally one or two boxes in between there, right? And that's how we know it's sinus tachycardia. QRS, just glancing at those, you know there's no chance that there's 3 boxes in between there, right? No, there's not. That means it's QRS is perfectly fine. So not a problem at all. So this is a sinus tachycardia all the way across. Beautiful. Now, let's talk about some tachydysrhythmias, rhythms that basically, lots of different rhythms that are too fast. Now, these are some of the ones that people have trouble with. Because sinus tachycardia itself is a toughie. And I'm surprised somebody didn't point this out. But sinus tachycardia itself is difficult. And the point is, it only, in this example, it says 101 to 180 beats. Now, that doesn't mean after 180 it's not sinus tachycardia, but we have other names for it. That's right. So let's talk about these too fast rhythms. Let me just scoot back. Stitch is sitting on my lap. He's a pain today. First one I want to talk about. So we're talking about things that are too fast. We're going to talk about tachydysrhythmias. So if we talk about tachydysrhythmias, we can talk about ones that are too fast, like supraventricular tachycardia. We're talking about tachycardia, right? So what does supraventricular tachycardia mean? Well, that means that the electrical activity, I can't even talk today all of a sudden. The electrical activity arises above the ventricles. That means the electrical activity rises above the ventricles and is supraventricular. So what happens is it causes a tachycardia, and there's a couple different kinds. I'm not going to talk about each one of them, but essentially what happens most commonly is either overexcitation of the SA node from things like caffeine and nicotine, stress, lots of different things. But the big one, caffeine is a huge trigger for what we call supraventricular tachycardia, or SVT. And of course, whenever we look at treating rhythms and treating any type of rhythm itself, what we need to know is is the patient symptomatic? I mean, anytime we have a ECG abnormality, so even sinus bradycardia, we don't have to treat sinus bradycardia unless it's symptomatic, because we know athletes, which I'm not in the athlete category, they have big, strong hearts, so their hearts beat slower. They're normally bradycardic, and of course would be normally slow. Get down, Stitch. You're gonna have to sit down. They're going to be normally slow, and then of course you don't have to treat them. You don't just start giving atropine to everyone because they have a slow heart rate, because it may be normal. So we treat symptomatic patients. Same with SVT. So let's look at a couple of these. There's also a way where we have, before I forget, re-entry SVT. So it's essentially can be caused by other accessory pathways that basically, here's a good example right here in this one. So atrial tachycardia, which we have a slide on, and then just re-excitation of that AV node causing overstimulation. So I love this term, paroxysmal. Paroxysmal supraventricular tachycardia. Wow, what a fun word, right? Say that 10 times fast. Paroxysmal supraventricular tachycardia, or PSVT or SVT. PSVT means paroxysmal. That means that it's transient, right? Just like my thought right at the moment. It's transient. It was there and then I lost it. Nicole on YouTube thinks Stitch is drunk. He may be drunk. I don't know. So paroxysmal means that it comes on and it goes away. So how do we check this? And look at this rhythm. Most of you on the rhythms, if you're not really comfortable with ECGs, you're going to look at this one. You're like, I have no idea what's going on. But anytime you're looking at a rhythm, if you get one that you just really can't tell and you're able to get a longer portion of a rhythm, bigger section, that's great. That's what you should do, because what you want to do is see what was happening. Like things are chugging along great. So look at this rhythm here. This rhythm's chugging along great. If you took your hand and you covered up this section of your, from here back, and you looked at just this rhythm and imagine you did that same thing for 6 seconds, everything's great. I mean, it's a great rhythm. So, that's normal. But what happens is when we look at the steps, what's the rate here? So Jack's an overachiever and apparently already counted 15 across here. So I'm just going to believe you. So that rate right now, and during this 6 seconds, was about 150 beats a minute. That's okay. That's way too fast. But is it regular? Is what's going on here regular? Is what's happening here regular? Well, I'm going to get my beautiful thumbs, and I put them up there, and I look, and I'm like, wow, I got a big space. So oh, there we go. There's my red pointer. I got a big space. I got another space the same. Then it gets smaller, but then it's just literally just tiny space. Hey, come here. Oh. Yeah, Stitch is definitely he's having a day. He's not having the best day. He's not happy. So then I have a tiny space right across here. That's absolutely right. So but it's regular in the middle, but it's too fast. If you just took this section and you multiplied it times 2, then you've got a really fast rate, right? But then what happens? Well, then somewhere right along this space, it gets normal again, and it's normal. Here it looks just like the same as it did before. So it was doing something normal. It did some craziness in the middle, and then it just got back normal again. We see this again when we're going to talk about a ventricular rate. But what happens is it was doing great. Then it got drunk here in the middle. And then, again, it did crazy stuff. It's going to regret. And then it went back to... I wasn't talking about you, Stitch. That was one of the YouTube people, not me. Then it goes back to being normal again. But that's the point. There's just this madness in the middle, and that's what we call paroxysmal. Sorry, Francis. Sometimes Stitch goes a little crazy. I don't know why. I think he has Tourette's. I'm just gonna be honest. I can always tell when he's about to do it. That's why I pulled him up here, because he's just like looking around like he's just about ready to yell. Sorry. Oh, okay. So as we look here, this is why we call it paroxysmal. It's normal. It comes and then it goes away. So before I talk about that, somebody already mentioned it once, but when we talk about SVT, it's really important to know that SVT, paroxysmal SVT, anything that's randomly coming and going, is usually a sign for something that's going to come and stay. and be very problematic. This is the same when you think about TIAs, transient ischemic attacks. TIAs, they come and they go and they come and they go, and you're all fine until you get the big one, right? And then it doesn't go away. It's the same with PSVT. If you're somebody who is drinking caffeine, like me, and you're, doing crazy stuff like me, and what happens is then you have an SVT. Luckily, I don't have PSVT. But then you end up, you have bouts of PSVT. What happens is eventually you go into SVT and your body's not able to convert. Anytime we go to an irregular rhythm to a normal rhythm, we call that conversion. Your body's not able to convert back to a regular normal sinus rate. Stitch is giving me like the porno look right now. I don't know what this deal is. But the point is, what happens is then eventually you're in sustained SVT. And those patients, you can't stay in SVT for very long. Some patients can. I mean, yes, they have runs of SVT and they're in SVT for a long time, and they, then they have to be treated. But what's the drug we need to give for SVT? This is really high yield. You got to know this drug. What's the drug? Somebody already said earlier, I think. That's right. So you got to give adenosine. You've got to give adenosine for sustained SVT. Adenosine interrupts the channels in the heart and essentially stops the ability for the heart to contract electrically temporarily. And then what happens is it basically just restarts. It's the funnest drug to give ever. If you get to do it, I recommend getting to see it because you just see a patient at least usually for a second. You flatline. And it's the only medication really that you need to give as rapidly as possible because adenosine only has a half-life of just seconds. So it comes, it's there, and it's gone. Just like my sex life. Anyway, that's one bad joke I had today. So another one I want to talk about, I talked about what happens, how do we know that things are sinus, right? How do we know things are sinus? Well, we know they're sinus because we've got those beautiful, wonderful P waves, right? They're right there before every QRS. And what do we call something when there's no P wave? We call that a junctional rhythm. And a junctional rhythm happens whenever we have a rhythm that doesn't have a P wave that's originating from below the SA node, usually in the AV node or the atrioventricular junction. So if I look at this rhythm, what's the rate down here? So let's follow the same pattern. Let's not skip ahead. 1, 2, 3, 12. I got 12. I hope it's 12. So I've got 12 here. So at rate of 12, so that's 120. So 120 or so. I mean, that's estimated, yes. But it's fast. That's the point. So tachycardia. So then when we look at the rhythm, I'm just going to tell you right now, if you didn't already look, it's beautiful. It's regular all the way across. The R to R's and the P to P. Well, the R to R's are great, right? So the R to R's, regular. And then you look at the next one. You look down and you say the P waves. Is there a P wave there before every QRS? No. There's no P wave. What's this? There's no P. That's not the P. That's over here. So we're looking at PQRST, and then just some madness down here, right? It's not, it's actually, the P wave is actually occurring. This is actually the P wave down here. But when you look at these, so many people get confused and they get hung up, right? You get hung up and you get confused, like, well, which one's the P? What you should be able to do is identify the QRS, right? If you identify the QRS, then you know that the P should be right before it and the T should be after it, right? So you just have to kind of, sometimes it requires a little bit of guesswork, but you just end up getting the hang of it, of just understanding that you've got, well, there should be a P wave right here causing this. Maybe you would say that little notch is, no. So there's the QRS, and then remember, coming back above the isometric line, T. Here's our T wave. So this is just a PQRST. This is actually a hidden P wave down here at the same time of the S. That's really bad. So then we got a PQRST, but there's no P waves. There's no P before the QRS. That's all you got to know. Before the QRS, is there a P? Is it upright and is visible? No. So then if it's not there, then that means it's a junctional rhythm. The rhythm's originating from the AV node. So that's a PQRST. That's how we know. PR interval, there is no PR interval, so it doesn't matter. You don't have to calculate that because you can't do it. QRS usually is always fine, but you still do it. The widened QRS, there's only one box between all those, which means it's 0.04 seconds. Beautiful. Now, here I just said this again just because I like to harp on it. Junctional rhythms, just think about that junctional rhythm means it happens at the junction or below the junction. And that's what's important. That's why we call sinus rhythms sinus. Now let's talk about some fun arrhythmias here. These are fun. When we talk about the irregularities, the weird ones, these are ones that are hard. These are ones that are so hard to really get down because they never appear the same way. You're going to get a rhythm and it's going to look different, but you just follow the process and you'll get it. So let's look at atrial flutter here. What's the rate here? What is the rate? About 8, right? The ventricular rate is about 80. Ventricular rate, because the QRS is the ventricular rate. Well, Kendall, you just said all you have to do is count the QRS complexes to get the rate. Yeah, I did, but now we're making it harder. That's the whole point. So you know that the P waves themselves, the P waves are essentially atrial depolarization, which should ideally, if the electrical activity is connected to the muscle tissue and working in harmony, every time a P wave happens, that's atrial depolarization. So then we can count P waves to count the amount of atrial depolarization, or the atrial rate. So what's the atrial rate here? Well, you could just literally count all the way across again and then multiply by 30, right? What you want to do is you want to see how many there are to each QRS complex. How many? We call it the how many there are to each one. So it's like a 3 to 1, a 2 to 1, a 4 to 1. So there are these little weird waves. What are these? These are really weird. Well, you see how these look almost like shark teeth, like a shark tooth or a saw, if you ever use a saw. I'm from West Virginia, so I've seen lots of saws. The important thing here is knowing that these rate, right? It looks like a sawtooth. They're called flutter waves. Now, there isn't much with ECGs that you can just memorize, but every time you see one QRS complex and this little boop, 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 all the way across in beautiful harmony, those are almost always sawtooth waves. They're called flutter waves. And when you see those, these are essentially not P waves, but what happens is these are atrial depolarization. And you can see how many there are to each QRS complex, 1, 2, 3. So there's about, there's 3 or 4 to each QRS. So you can see that atrial rate's much faster than the ventricular rate. So when you look at the rhythm, is this rhythm regular or irregular? Well, if it's regular, that means there's 1 P before every QRS. The R to Rs and the P to Ps are a 1-to-1 ratio, and it's correct. So it's an irregular rate. And this is where it gets confusing. Is it doing the same thing over and over? Is it regularly irregular? Or is it doing literally, there's no pattern whatsoever? Well, if I folded this into an origami set and took it and cut it and laid them all over top of each other, it's doing the same thing over and over and over. People would be very cautious to call this regular. Well, it's irregular, but it's regularly irregular. It's doing the same thing wrong over and over and over again. So that's regularly irregular. That's right. It's always weird for me when I'm so used to our GoToWebinar stuff and other things, and it has a name on there and it has whatever you type in. And then YouTube, it shows up whatever their weird name is when you signed up. So it's funny for me with some of people's names, duck butt. So anyway, you can see that this is irregularly irregular. P waves, well, you can't really tell that they're there, but those are those characteristic sawtooth waves, flutter waves. So that's why we call this atrial flutter. And of course, this can be very fast. I mean, you can have way crazy rates. What's wrong with all of these atrial arrhythmias? The atrial arrhythmias have problems because what happens is when the ventricles or the atria relax, what happens when that happens? Well, they fill with blood. If the atria contract really fast, they never slow down to catch a breath and fill with blood to be able to pump blood into the ventricles. So what happens is they're just going at a fast rate, right? And I can't do this at the right speed and correlation. But the point is, the atria never stop contracting at this fast rate, so the ventricles are never able to the atria are never able to fill completely with blood. so then they can't pump enough blood to the ventricles. And then, of course, you have decreased cardiac output, which then just further exacerbates the problem. Here's a couple of examples of flutter waves. And this is important because this is one that I feel like you can try to identify very easy. But the waves always kind of look like this sawtooth pattern. These are not pointy waves like the last one, but they are very characteristically, they're literally flutter waves. They're all the way across the board. Here's a 2-to-1 ratio, so there's 2 to 1. Here's a 3 and then 4 to 1, so 4 to 1 ratio, so 4 to 1 ratio. So you can kind of see the difference there and how the cardiac output is different, and how you'd have problems with cardiac output if you had 4 to 1 versus 2 to 1. And that's absolutely right, because you would have a lot decreased blood flow. Now, the most high yield one that you absolutely have got to be able to identify, and I feel like it's the one curveball that comes out of nowhere that so many people have trouble with, is atrial fibrillation. So how do we identify atrial fibrillation? How do we identify atrial fibrillation? How do we identify atrial fib? Well, let's look at the rate. Follow the exact same process. Don't skip ahead. So how many, there's a QRS right here, by the way, right behind this little atrial heart alarm clock, who's freaking out for fibrillation. So how many, what's the speed here? 1, 2, 3, 4, 5, 6, 7, 8, 9. 9, right? Sorry. So there's 9. So the ventricular rate's about 90. Now, okay, let's just go with that for now. What's the rhythm? What's the rhythm? Well, get your beautiful thumbs out and take a look. Well, it's wide, then it's short, then it's wider, then it's shorter, then it's wide, then it's really short, then it's wider, then it's really wide. It's not doing the same thing. There's no distance between any of these is the same. Well, why would that distance be changing? Well, what causes the QRS complex to fire? The QRS complex fires because of an atrial impulse, right? The firing from the SA node goes down to the AV junction, then bam, causes the QRS complex to fire, the atrial depolarization. So is this regular or irregular? Well, it's irregular, right? So if it's irregular, then is it irregularly regular, or regularly irregular, or irregularly irregular? Well, there's no discernible pattern. There's no discernible pattern whatsoever. And if you tried to go ahead and try to find the P to P, you can't. You can't find the P to P, because where are the P waves? Well, here's where you have the difference between what we would call junctional rhythm and fibrillation. Fibrillatory waves are just imagine quivering, right? Quivering, fire, quivering, fire, quiver, fire. It's really just like being electrocuted, I guess, or tased at just a random interval, because you're like freaking out and then you just fire. But it's no pattern to it whatsoever. And that's exactly what fibrillatory waves are. So where's the P wave? Well, let's just start right here. So that might be a P wave. No, QRST, no P wave, QRST. There's a P wave right there, right? QRST, nothing, QRST, nothing. There's no P waves. There's no discernible P waves. And you can tell that it's getting regular all over the place. And that's how we can tell that this is irregularly irregular. And every time you get an irregularly irregular rhythm, and you have QRS complexes that are changing distance over time, it's very likely that it's atrial fibrillation. Unless you don't have if you have wide QRS complexes, that's obviously a much more serious problem. But that's where you should always have on the tip of your tongue atrial fibrillation, because you're always going to get this thrown at you because it's so common as people age and they end up with atrial fib. What's the big problem with it? We worry about because the atria are just quivering and the ventricles are contracting and the atria are quivering and contract and then randomly, and they're not working in unison. That means, again, the blood flow from the atria are not going to the ventricles, and if the ventricles aren't able to fill, then it's not going out to the rest of the body. That's absolutely right. So what do we do for this? Well, there's lots of things we can do for atrial fibrillation, but you got to worry about the long-term problems, because you can develop blood clots in the right atrium, and those can travel out to the body and cause strokes and other problems, and that's really the big worry with AFib. So they're probably going to be put on coagulation therapy. And of course, we can cardiovert those patients as well. We can give them medications to help slow their heart rate down, calcium channel blockers like diltiazem or cardizem. That's right. So here's a good example, just a weird one that sometimes, I just want to mention this because I hear it all the time. Atrial fibrillation with RVR. You've probably heard that. I remember when I heard that the first time, I didn't know what the heck. I didn't know what the heck that was. It means it's a rapid ventricular response. That means essentially the atria were misfiring and fibrillating, and what happened was at some point the ventricles got a rapid ventricular response and started beating at a super fast rate. So it's a very high ventricular tachycardia that's very irregular. And this is very difficult to determine the difference between rapid atrial fib with RVR versus supraventricular tachycardia. It's very difficult to distinguish, and that's why you need to get a 12 lead to be able to get the difference. And that's definitely a thing. Yeah, so we'll move on. So let's talk about the cardiac arrest algorithms here, just so we can go over these before we finish up. So monomorphic VTAC. Now, first off, there's monomorphic and polymorphic. Mono means one. Morphic means changes. So one change, ventricular tachycardia. So it's going to look like the same every time. So first off, what's the rate here? Well, I can tell you that these are giant QRS complexes. And this, every time you see something like this, if you see something like a big giant wide, it's probably could be a PVC or it's a giant QRS complex. So how many are there? 18? I think I counted real quick. So there's about 18 of those QRS complexes across there. So maybe there's 17, I don't know. So there's 18. The point is, it's very fast. It's a very fast rate. Very fast, way too fast for the 6-second strip, and that means about 180 beats a minute. Now, what's the rhythm? What's the rhythm? Looking across all of those peaks there, it's pretty regular. It's pretty regular. But is it regularly? Is it a regular rhythm, or is it irregularly irregular? Well, it's irregular because there's no P to P and R to R in synchrony because you can't see a P to P. But what there is it's doing the same thing the whole time. It literally looks the same all the way across. And that makes it's doing the same thing over and over, so it's irregularly regular or regularly irregular, however you want to put it. I always say those and I swap the words, so it means the same thing. So anyway, look at P waves. There's none here. There's no P waves. There's no P waves present. You can't see anything. You see nothing but giant ventricular contractions because of these giant QRSs. The PR interval, of course, then means it's absent, and the QRS here is giant. So where's the QRS? Are there more than 3 boxes in between all of this? Yes, there's 5, 6, there's 7 boxes of QRS in between here. So 7 times 4 is 28, so 0.28 seconds of a QRS complex. It's very wide tachycardia. Wide tachycardias are often ventricular tachycardia, is usually what it means. What do I do with this rhythm? What's the treatment here? Give them a hug, right? Just give them a hug. So the first thing you want to do is always, if you see a rhythm like this, check the patient. Check the patient. What do you need to do to check the patient for? You need to check their pulse. Because you can have ventricular tachycardia and be talking, walking just fine. Now, you can't do that for very long, but you can do it. And that's what's really important. It doesn't work forever, but you can do it. And that's right. You can see that definitely the important thing is that it's you got to check for that pulse, because if they don't have the ACLS algorithms with this one, this is just a trick question that always pops up. It's a big paramedic, nursing, medical school, all of them. What's the first thing you do? Check the patient. One, because it's easy to look like they have VTAC if the patient is moving, if they're on the monitor. Number 2, pulseless VTAC is treated differently versus VTAC without a pulse. If you don't have a pulse, you need CPR and defibrillation. If you have a VTAC with a pulse, you have to be cardioverted. So you need to be electrically cardioverted using a synchronous cardioversion, meaning it just works differently. So I hope you know the difference of those. So I just got those 3 different differences here of what the things you need to do differently. I'm not going to go over it in big detail because I am running way behind. So for polymorphic VTAC, it's just different. Now this is where you have torsades de pointe. and I'm sure I butchered that French name, but is the point, and torsades, as we call it. Polymorphic VTach. Well, what does polymorphic mean? That means it's changing. It's multiple changes in ventricular tachycardia. But let's not skip the process. What's the rate? Super fast to the end, right? What's the rhythm? Well, it's irregular, and it's irregularly irregular. Now, what was the other irregularly irregular rhythm that we had? Atrial fibrillation, right? Well, this one also is irregularly irregular. Polymorphic VTach. Now, polymorphic VTach, look for those P waves. No P waves. Is it junctional? No, just VTach. I mean, it technically is a type of junctional, but it's VTach, ventricular tachycardia. PR interval is gone, but reason it's VTach is we look at that QRS interval and it's wide. Every single one of these ugly QRS complexes are really wide. I mean, if you could put your whole thumb in there if you had tiny thumbs. Thank goodness I don't have tiny thumbs. All the way across here, you can see the big giant wide QRS complexes. So you can see that's greater than 0.12 seconds or 0.10. Either way, 3 boxes big. What do we worry about this? Well, polymorphic VTach is often torsades de pointes can be caused by several different things. It can be caused by there's a conduction defect that can cause torsades. There's R-on-T phenomenon can cause torsades. But what's important to know about this is that it needs immediate defibrillation, right? These patients are in big trouble. Now, you could have a bout of this, a short paroxysmal bout, but remember what we know about anything that's paroxysmal? You need to be worried about it. So these patients usually have an impending cardiac arrest, well, this is cardiac arrest, but it doesn't go well after this. So we need to make sure we're worried about these. What's the medication we give people with this? What's the medication? If there was only a medication that relaxed muscles. Ooh, yeah, I don't know. I just can't think of it, right? These patients are often going to be given magnesium, right? You're going to end up getting magnesium to calm the muscles down, especially because they're very irritated. Just like anytime something's fibrillated, it's just twitching all over the place. Twitch, fibrillating. Fibrillatory waves. Now, we already got this. I already kind of talked about this slide, so I'm going to skip. Oh, maybe I didn't. Yeah, I did. Sorry. Now, the next one I want to talk about is ventricular fibrillation. So, ventricular fibrillation. This is something I just want you to really not just guess every time you just see a squiggly line, you just guess VFib. Please don't do that because it's pretty easy to be able to tell. Let's look at the rate here. What's the rate? I can't tell the rate, Kendall. That's absolutely right. Great answer. What's the rhythm? It's a bunch of chaotic mess. I can't tell. Absolutely right. Good answer. Where are the P waves? Look, what am I, a magician? I don't see any P waves. What's the PR interval? This is not funny. And that's right. Nothing is discernible. But what's important here is that there is nothing discernible at all, ever. There's no discernible pattern. Now, when I look back, if I go backwards and look differently at polymorphic VTach, look at these giant, beautiful waves in here. I mean, these are beautiful, giant VTach waves. VTach waves always look like this. Well, not always. They can be a little shorter. I mean, and I think they get upset when they're the shorter ones. They usually look like these waves right here, these short ones, these little short, fat ones, or these big, beautiful, tall ones. And that's not a discrimination joke against short, fat people. I'm short and fat. Anyway, the point is, I'm going to get so many hate comments for this, so I guess it's a good thing it's my last Picmonic webinar today, I guess. The point is, there's no discernible pattern whatsoever. It's literally just it's quivering all over the place. It's not doing any kind of, if I was to isolate this and throw it into a normal rhythm, it's nothing that would look like anything of a QRS complex, right? Is not really anything that I can tell. And that's absolutely what is important. Now, as you go through this and you look at this, it's like, well, what's the difference between this and AFib? Well, this is not atrial fibrillation because atrial fibrillation is usually very, very short, very fine waves, whereas ventricular fibrillation is a lot of larger waves. Look at the isometric line. It literally goes all the way. Well, I can't move my cursor all the way across very well, but it's literally a beautiful line all the way across the middle, and there's literally deflections above and below. The atrial fibrillation is just going to be little tiny deflections above, because those are P waves which go above the isometric line. This is going above and below, but not in giant, beautiful waves. And it's very chaotic. There's no pattern. That's ventricular fibrillation. Now, there's a difference. One of the things we do call this sometimes coarse VFib, which is what I just showed you. And then there is something technically called fine ventricular fibrillation, which is literally just a whole bunch of nothing all the way across here. You may see people sometimes, treat this like an asystole rhythm or whatnot, or try to call asystole fine VFib and shock it. I think that's a debatable thing, and this is fine VFib, debatably, and that's just where it's because it's not as tall. Now the last one, asystole. A means without in medical terminology. One of the biggest things you need to learn in medicine is making sure you know medical terms so you can get all of this stuff correct. A means without. Systole means systole, so the contraction without contraction, cardiac standstill. So what happens? Well, there's nothing. The end. We're done, right? What's the rate? There's no rate. Now, there may be P waves there. That's what's really important. You could have a systole, and you could still have some P waves in here. Maybe there's just one little blip of a P wave. And that's one of the biggest things I struggled with when I first became a paramedic was really being able to say, okay, well, what's the deal here? Being able to, there's still electrical activity. We should do something. Well, it's still asystole, unfortunately, because there's still electrical firing that may be happening in the atria, which could cause atrial depolarization, but the heart may not actually be responding. So there's nothing absolutely dependable. There's nothing going on, and that is asystole, and that's really all you have to know about that. I think it's the easiest one to know because it's just nothing, right? Here's a good example of our P wave asystole. So there's still an electrical activity firing at the SA node, but there's nothing going on elsewise. It's all done, went to sleep, and it's just gone. P wave, and there's nothing else, and that's what you need to know. One really important one, and don't you miss this trick, is pulseless electrical activity. PEA, right? Look at this rhythm. What's the rhythm here? This is beautiful. What's this person's pulse rate? Pulse rate's 0. But the heart rate, the electrical heart rate, is measured, and it's probably, 120? I don't know. It's beautiful. It's a good, nice, beautiful rate. But the thing of it is you may have electrical activity in the cardiac monitor, but the patient may actually not have a pulse. That's where you always need to make sure you have that rule of check your patient, treat your patient, not the monitor, because this one could get you in trouble. I don't see beautiful PEA that often, maybe more than once in my entire life. That's like at a rate of like 50 that I thought was sustainable for life. But that was just because there were so many drugs given that the electrical activity I felt like had to at least be going on. But unfortunately, the heart muscle just wasn't responding. So here's our same review of going over what you need to know. Follow this same process. Just do it. What's the rate? Is it slow? Is it regular? Or is it fast? What's the rhythm doing? Is it doing the same thing over and over? Or is it just doing a bunch of crap all over the place? What's the P waves? One before every QRS is the most important. And then, of course, each one, they need to be upright and consistent. They need to look the same all the way across. What's that PR interval? Less than 0.2 seconds. Super important to make sure that PR interval is less than 0.2 seconds. And then looking at the QRS last, which is, depending on what book you look at, it's 0.10 to 0.12 seconds or less, or 3 small boxes. If you're seeing things that are wide QRSs, those are usually ventricular arrhythmias. And that's just what you know. And as I think Jack mentioned earlier, we give after any kind of arrhythmia, ventricular arrhythmia, after the fact, we usually give lidocaine, and that's right. So guys, that's all we have in here for our webinar today. I'm glad you could join us. I'm so sorry for the problems that we had with if you were on our GoToWebinar side. I hope you jumped over to YouTube so you could join us. Duckbutt3385, I am not going over the heart blocks today, and I am sorry, but I can tell you I do make lots of videos myself. You can follow us on YouTube at Picmonic Video. You can look on YouTube for my channel if you want, and follow me myself, because I've been making lots of videos myself, and we'll be making some on heart blocks just because I have a lot of really bad, corny jokes for that, and I think it'll just be a lot of fun. This is actually my last webinar with Picmonic. Aside from any kind of guest appearances that I'll be doing in the future, because I am going off to residency, so you'll have to find me otherwise. Sorry about that, but maybe I'll be in as a guest, maybe in the future. I don't know. I can't guarantee anything, but what I do know is this is definitely my last one. If you have any questions specifically, you want to check out Picmonic, I absolutely recommend it and love Picmonic. You should check it out. Go to can't even talk. Check out Picmonic for free on the website, picmonic.com. You can also email. If you have any questions, you can go in there and actually email them feedback at Picmonic Video as well. You can follow me on Twitter at Picmonic Kendall, and then you can also sign up, and you can just message us straight from our site. In the background, we've got Marley, who is our master nursing scholar, who also has been answering lots of your guys' questions on YouTube as well as GoToWebinar, and taking care of a lot of the details. I don't see any big questions aside from just asking about more content and where we're going to be. But definitely appreciate you joining in with us. Stitch is always with me, and I'm not sure what we're going to do for the hospital stuff. Come here, Stitch. He's being moody now. Now he's not in the mood to doing anything. But we're going to be going to, we're actually moving back to West Virginia from Phoenix. So you'll find us at, I'm actually going to be at Charleston Area Medical Center doing residency there for internal medicine. So it'll be lots of fun. Still be doing lots of teaching and lots of nursing education, which is one of my passions. Definitely lots of fun. I hope you learned something today, guys. I know it was a little slow to get started. I went literally 20 minutes longer than I expected. And that was not on purpose. So thanks for sticking around. Lots of people here. Like I said, you can follow Picmonic on YouTube at Picmonic Video. Recommend it. You should check out Picmonic for free if you haven't, because you're hurting yourself if you haven't checked it out. And then if you wanted to follow me on YouTube, you can follow myself. Just go on there. Just search Kendall Wyatt on YouTube. You'll find my channel. It's right there. I think it's Kendall Wyatt MD. Maybe is the link. But I honestly don't even know. It's I should probably look that up. But anyway, thanks for joining in, and for everyone, and especially hats off to all of my favorite webinar listeners like Judy and my new favorite Duckbutt3385. Oh God, I don't see too many other questions. But other than that, guys, we appreciate it, and as always, good luck studying.